Folic acid deficiency in megaloblastic anemia. Folic acid is also known as vitamin B9 or pteroid glutamate. The reason it's known as pteroid glutamate is because it is synthesized from pteroic acid and glutamic acid. The form in which it is found in diet is folic acid polyglutamate. Some of the dietary sources of folic acid include vegetables, fruits, animal products including milk, liver. Note better, goat milk and powdered milk do not contain folic acid. The absorbable form of folic acid is folic acid monoglutamate. The absorption is facilitated by active and passive transport in a pH of 7.4. The primary site of storage of folic acid is in the liver, and also the liver can store about 5 milligrams between a period of 3 to 4 months. So the functional form of folic acid is tetrahydrofolate. Now let's get into metabolism so that we can understand how polyglutamate, the available form in diet, is finally converted into tetrahydrofolate, which is the functional form. The bioavailability of folic acid depends on the hydrolyzation of folic acid polyglutamate to a more easily absorbable form through the intestines, that is folic acid monoglutamate. So in this case, bioavailability means the fraction of folic acid that has been ingested that will reach the systemic circulation. So the hydrolyzation reaction of folic acid polyglutamate to monoglutamate is facilitated by two main enzymes. So the first enzyme is polyglutamate hydrolase, and the second one is glutamate carboxypeptidase. These enzymes are located in the luminal surface of the small intestines. After folic acid has been taken up by the enterocytes, a methylation reaction takes place where the monoglutamate is now converted into methyl tetrahydrofolate by the help of the enzyme dihydrofolate reductase. After methyl tetrahydrofolate has been formed, it is now time for the folic acid to exit the enterocytes, and this is through or via the basolateral membrane, and it's either taken into the systemic circulation or the enterohepatic circulation. So in the systemic circulation, about 66% of the folic acid is bound to albumin, 33% is left free, and 1% is bound to folic acid binding protein. Thereby is taken up to the cells where it's to be utilized. Folic acid enters the cells by either binding to the reduced folate transporter 1 or reduced folate transporter 2 or folate receptor 1 alpha or folate receptor 2 beta. Once folic acid is inside the cells, its transport is now mediated by clathrin-mediated endocytosis. Intracellularly, methyl tetrahydrofolate is now demethylated to form tetrahydrofolate, which is the functional form of folic acid, as we stated initially. So, tetrahydrofolate can accept the glutamic acid chains, which make it more stable and prevent it from exiting the cell. So, it acts as an anchor. Functions of folic acid. So, the most important function of folic acid is synthesis of methionine and thiamine. Other functions are purine synthesis, histidine metabolism, and conversion of serine to glycine. In thiamine synthesis, deoxyuridine monophosphate and methylene tetrahydrofolate, under the influence of the enzyme thiamine synthase, are converted into dihydrofolate and thiamine. So thiamine is one of the pyrimidine bases that make up DNA and also help to differentiate DNA from RNA. So in this case, DNA has thiamine while RNA has uracil as a nitrogenous base. In the absence of thiamine, uracil is incorporated to what is meant to be purely DNA, altering DNA synthesis. So the result of this is asynchronous maturation between the cytoplasm and the nucleus. Causes of folic acid deficiency. The first one is inadequate dietary intake. This can be in cases of pregnant mothers, which require more folic acid, and also in rapidly growing children. The second one can be inadequate absorption, like in cases of chronic diarrhea, celiac disease, topical sprue, and also in small intestine resection. The third one can be congenital abnormalities in folate transport and metabolism. And the fourth one can be various drugs that alter folate metabolism, including methotrexate, mycophenolate mofetil, trimethoprim, and various immunosuppressive drugs. Folic acid deficiency anemia presents with recurrent infections due to leukopenia, hemorrhages due to thrombocytopenia, abdominal pain, chronic diarrhea, failure to thrive, also reduced appetite, among other symptoms. Laboratory investigations. First, we can do a complete blood count. The mean corpuscular volume is greater than 100 femtoliters, except in situations where iron folate deficiency coexists with iron deficiency anemia. In this case, the mean corpuscular volume will be within the normal ranges, but there will be an increased red cell distribution with thrombocytopenia and neutropenia might also be present. So in the peripheral blood smear, we'll find macrovalocytes, where we'll find that the neutrophils are large and hypersegmented with more than 5 lobes. Bone marrow is hypercellular due to erythroid hyperplasia. We can also check the serum folic acid levels. The normal range is from 5 to 20 nanograms per ml, and the deficiency level is below 3 nanograms per ml. RBC folate levels are a better indicator of chronic deficiency. So the normal range of RBC folate is from 150 to 600 nanograms per ml of packed cells. Serum lactate dehydrogenase levels will also be elevated due to ineffective erythropoiesis. For treatment, we can give folic acid at a dose of 0.5 to 1 milligram per day for 3 to 4 weeks. When the diagnosis of folic acid deficiency is doubtful, we can do a therapeutic test. This is done by giving 0.1 milligrams of folic acid and check for reticulocytosis after 72 hours. Folinic acid is used in drug-induced folic acid deficiency anemia. Transfusions are indicated only when the anemia is severe or when the children are critically ill.